Dear audience, dear chair, I would like to present my PhD thesis investigating the therapeutic approaches of immune-mediated inflammatory skin disease. I am Máté Krebs, a 6-year medical student and a first-year MD PhD student, representing the Department of Dermato-Oncology, Venerology, and Dermatology at Semmelweis University. My supervisors are Péter Halló and Lajos Vince Kemény. My vision is to improve the quality of life of people with immune-mediated inflammatory skin disease by assessing and addressing the risk associated with targeted immune therapies in immune-mediated inflammatory skin disease. I have two specific goals. The first is about investigating the infection risk of JAK-STAT inhibitors in immune-mediated inflammatory skin disease. It was launched in September 2024. And the other is also meta-analysis investigating the risk of inflammatory bowel disease in patients treated with IL-17 inhibitors. I would like to conduct both with the methodology of systematic review and meta-analysis. I would like to talk about the first project. The JAK-STAT signaling is implicated in many immune-mediated inflammatory disease called for a short IMiDs. And this pathway has become a major therapeutic targets for IMiDs such as psoriasis, vitiligo, alopecia, hidradenitis. And they are working by blocking the JAK-STAT signaling and offering a significant relief and reducing the symptoms and the inflammation answers to the disease. And it is increasingly used, and it is in the United States, the statistics indicate that approximately 200,000 people are prescribed the JAK-STAT inhibitors, but despite the effectiveness, the JAK-STAT inhibitors comes with serious risks, which the FDA has addressed and specifically highlights the serious risk infection. And as a result, many physicians are concerned about the serious risk infection, and it creates an unmet need to reduce this fear around the JAK-STAT inhibitors. We would like to evaluate the infection associated with JAK-STAT inhibitors in immune-mediated inflammatory skin disease, especially in patients with atopic dermatitis who have a baseline elevated risk for skin infection. And the primary question driving our research is, are JAK-STAT inhibitors associated with increased risk of serious infection in immune-mediated inflammatory disease? And to structure our research, we use PICO framework. Patient with immune-mediated inflammatory skin disease, we would like to compare the JAK-STAT inhibitors to placebo or non-JAK active comparator, and our outcomes, the presence of infection. Our hypothesis is that the patient with immune-mediated inflammatory skin disease treated with JAK-STAT inhibitors have not significant risk of developing serious infection. And the clinical implication that balancing the disease control and the infection risk is key to provide a safe and effective treatment. And to check the feasibility, I collected 3 key articles, all of them investigated the patient with atopic dermatitis. They compared the baricitinib to placebo, and there were lots of kind of infection outcomes. There is the search key. It consists of 3 domains. The first domain reflects to the intervention. The second one reflects to the different disease, and the third one to the RCT, because we would like to only include RCT to provide the highest evidence, and it was conducted in 3 databases. There is the flow chart. At the beginning, we have 5,000 hits, and at the end, we have 69 eligible full text. And I did a citation tracer, and we couldn't find any more feasible RCT. This is the progress. We are at the phase of data extraction. The 20% are done. And I would like to talk about the second project. The interleukin-17 are strong inducers of inflammation, contributing tissue destruction in image, and the IL-17 inhibitor successfully used for various images such as psoriasis, hidradenitis suppurativa, and it was considered as a potential treatment for IBD, but the clinical trials show no efficacy and even worsened the symptoms or caused relapse in IBD. And studies explored the association between hidradenitis suppurativa and the IL-17 inhibitors. Additionally, new IBD cases were reported after the IL-17 inhibitor therapy. The patient with hidradenitis suppurativa have around 5.6-fold increase baseline risk for IBD, and there is no consensus on whether it is necessary to screen for IBD before initiating a treatment or not. So our aim to evaluating the risk of inflammatory bowel disease in patients with immune-mediated inflammatory disease undergoing IL-17 inhibitors therapy. The clinical question that does the use of IL-17 inhibitors increase the risk of IBD, and there is a PICO framework also, and we would like to compare the IL-17 inhibitors to placebo in patients with immune-mediated inflammatory disease, and our hypothesis is that patients treated with IL-17 inhibitors have a higher incidence of developing or experiencing exacerbation of inflammatory bowel disease. So the clinical implication to improve the patient's safety and optimizing the treatment strategies. There is the primary research. It also were conducted in 3 databases, and we around 10,000 hits. Summary, we have 2 ongoing projects. I would like to submit the first one in September and the second one around next year, January. And I would like to close my presentation with the words of Estée Lauder, and never dreamed about success, I work for it. And thank you for your kind attention.
My question would be that how would you define the term serious infection? So is there any definition for this? And if so, how do the different papers report this, uniform or differently?
Thank you for your question. Fortunately, this is the same, there are same definitions in the different RCTs. When the serious infection, it means that the serious infection results in death or requiring hospitalization or requiring IV antibiotic treatment or causes permanent disability. And it is reported or events only, or patient with events, or they are reporting an exact number or just listed the adverse events, and I have to select which was infection or which were not, and this is a bit complicated and causes a bias because it's subjective, because there are a bit of serious lymphadenopathy can be caused by infection, but also can be caused maybe cancer.
I would like to ask you if you found enough RCTs for your second project.
Yes, we have enough RCTs. There is a complication with the hidradenitis suppurativa because we would like to do a subgroup analysis of the hidradenitis suppurativa, but we only have 1 RCT in that topic, but we can do it just not meta-analysis but a systematic review. But we can involve in the meta-analysis.
I was wondering if, besides the infection, are there any FDA warnings about the JAK inhibitors?
Yes, there are more. The cancer risk and the major vascular cardiac events and the thromboembolism and the highlights the death. Yes, and the serious infection. And we only investigating the serious infection.
I have a question regarding the second project. So there are some studies that report having HS increase the risk of IBDs. How do you plan to differentiate these from IL-17 induced IBDs versus like HS increased risk of having IBD? Are you planning to do subgroup analysis for that? Yeah, we can, and we will only include those RCTs that at the beginning screened for IBD. So there is no IBD at the beginning.
So maybe it was caused by ER17 inhibitors.
I have a question. You mentioned that the definition of serious infection are well known and similar in the articles, but what challenges did you have during the data extraction? Maybe you have others.
Yes, as I mentioned, that I have to collect them, and maybe that are lots of kind of infection, and the database is very long, and yes, this is maybe cause maybe some challenging.
I would have a question regarding the second project, that how long is the follow-up time you want to screen the IBD? Because, so you start the IL-17 therapy, and then you check if it is within 5 years, 10 years, or 1 year, or so. How is it?
It is not long studies, unfortunately. Maybe maximum 1-2 years, but the median follow-up may be around 16 weeks.
So if there is an IBD induction, it comes early, as I understand.
Yes,
that what
yes.
Okay, thank you.
I also have a question regarding the second project. So will you distinguish between different types of IBDs, such as Crohn's colitis and colitis ulcerosa?
Yes, if there are enough data, we can do that, the subgroup analysis, and extract the numbers based on the different type of hidradenitis suppurativa, if there is enough data.
Okay, and do we screen for IBDs in Hungary in this patient population, and how do we screen these patients if we plan to induce biologics?
I think there are more options. Maybe the gold standard is the calcineurin, calprotectin from the stool, or the addressing the clinical symptoms. But the gold standard is the colonoscopy. But as far as I know, there is no capacity to do every patient colonoscopy.